Good evening, everyone, and welcome to the first annual Oral and Maxillofacial Surgery Global Surgery Day panel event. It is a pleasure to welcome so many of you from around the world and across the country. On behalf of the sponsor of this event, the Global Surgery Student Alliance, my name is Jack Harris, and I will be the moderator tonight. I'm currently a rising fourth-year dental student at the Harvard School of Dental Medicine and National Dental Lead for the Global Surgery Student Alliance. The Global Surgery Student Alliance is the national student-run global surgery working group for the United States, affiliated with Incidence, the International Student Surgical Network. GSSA believes that students are a valuable resource for the advancement of global surgery. We also believe that being unified in our efforts will help further our initiatives and can also facilitate more collaboration amongst overall global surgery efforts, both now and in the future. By exposing students to the field early on, we also hope to help them build their surgical careers with global surgery in mind. Ultimately, many students are willing and able to make significant contributions to global surgery, and we hope to be a resource that facilitates these efforts. Today's panel is in honor of Global Surgery Day, which is celebrated internationally on May 25th and aims to spread awareness and recognition regarding the inequity in surgical access and outcomes for patients around the world. Before I introduce our guest speakers tonight, I would like to first go over some housekeeping rules. Each presenter will provide a lecture for roughly 30 minutes, followed by a Q&A session using questions provided through the registration link. There is also a Q&A chat function at the bottom of your screen, which will allow you to ask your questions in real time. The event will end promptly at 9:30 Eastern Standard Time. Our first lecturer is Dr. Salim Afhsar, attending surgeon in the Department of Plastic and Oral Surgery at Boston Children's Hospital, and faculty member of the program in Global Surgery and Social Change at Harvard Medical School. Our second lecturer is Dr. Shahid Aziz, professor in oral and maxillofacial surgery and plastic reconstructive surgery at Rutgers University, and co-founder and president of Smile Bangladesh, a nonprofit medical organization dedicated to caring for children and adults affected with facial cleft deformities in Bangladesh and around the world. Now I will turn it over to Dr. Afhsar for his presentation.
Thank you for inviting me to join on this day. I am very happy to sit here to present with you some of my work in global surgery. As a background, I am a pediatric maxillofacial surgeon, and I have background in engineering and design. I'm a tech entrepreneur. I'm a board member of multiple companies, an advisor, and I'm also a faculty member. Now, the old definition of global surgery is really around just mission trips. That's what most people think of when you think of global surgery. And Paul Farmer, whose photograph is on the right here, he stated that global surgery is the neglected stepchild of global health. In fact, in 1980, Dr. Mahler said the following: the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. I beg of you to give serious consideration to this most serious manifestation of social inequity in healthcare. Neglected. Well, how neglected is it? 5 billion people cannot access safe surgery when needed. Now, of course, oral and maxillofacial surgery is a subset of this measurement, but the reality is, when you look at the world, the darker the red, the bigger the inequity or lack of access to surgeons, anesthesiologists, or obstetricians. Then you can see these numbers on the right side. 143 million more surgical procedures are needed in low to middle income countries. 33 million is the world's population face catastrophic expenditure paying for surgery and anesthesia. And it's been shown that investing in surgery is actually economical and affordable. And that finally, surgery is an indivisible and indispensable part of healthcare. Now, this is for looking at orthopedic, obstetric, and general surgery care. There is actually no data that exists for specialties such as oral and maxillofacial surgery. We also know that 90% of the products and services that have been designed and engineered currently benefit only 10% of the world's population. And that the poorest 1/3 of the world receive only 6% of the worldwide procedures. The question is it worse within oral surgery? Is it better? We don't know. But what is global surgery really about? Many people will have different answers. They'll say it's about impact investing or donating money or mission trips. It's about fundraising. It's about teaching, public health, policy. It's about capacity building. Well, let's redefine it. I define global surgery as a rapidly growing multidisciplinary field with an aim to increase access and quality of equitable surgical care across health systems around the world. Now, there's some fundamental questions that must be answered. What is optimal surgical care? What are the barriers? And how do we implement improvement? So now we know that global surgery is more than mission trips. And at its core is about advocacy, education, research, and clinical care. And this is really important because it's not that any one element is more important than other. When we step back and look at healthcare as a system, you have to understand it in every dimension. And when you identify the different components, then you can identify a space or an area where you can contribute. Now, 2015 was a really pivotal year. First, it was the year that I returned back to academics. I spent some time starting several companies, raising money, spending time in the industry. I came back through the business school, first through the iLab, and then joining the Innovation Digital Health Accelerator at Boston Children's Hospital. And when I joined Boston Children's Hospital at that time, I joined the program in global surgery and social change, which was founded by Paul Farmer. And the global surgical component was by John Mira, who happened to be the chairman of Boston Children's Hospital. And it's during that time, I came across and decided that the role that I wanted to play was to bridge the gap that exists between academics and entrepreneurship. You know, academics is really about studying problems, but entrepreneurship is about solving problems, deriving solutions. There needs to be a gap if we're trying to address problems in the world around global health and global surgery. And I felt that I could bring credibility as well as a platform and access to influence change. Now, during that same year, Dr. Mira became the commissioner and led one of the most pivotal publications. It's the Lancet Global Surgery 2030 in the middle. At the same time, there were two other publications. One was the first essential surgery textbook, the third edition, which was updated and expanded into every dimension. And the last was a resolution set forth by the World Health Assembly that identified strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. The Lancet Commission on Global Surgery set a framework where it identified surgical care delivery involving four main components: workforce, which involves training, education; data and information management; financing, insurance and economics; and then healthcare delivery and management. And with that, we designed the National Surgical Obstetric Anesthesia Plan, also called NSOAP. And that NSOAP framework touched infrastructure, workforce, service delivery, financing, management of data, and governance. And this became a launching point for governments to organize. So I led the first national surgical obstetric plan to be developed in the world in Zambia. And this is kind of the process where we work with the Ministry of Health and the different ministries and got their support. We did situational analysis and assessment. We then had large stakeholder meetings, engagements. We drafted and validated. We monitored and evaluated. We then moved the costing, figure out how much would it cost to advance surgical care, and then set policies within government, and then the government then went and implemented. And that led to this publication, which was for 2017 to 2021, the NSOAP for Zambia. Now, after that experience, I recognized a couple of things. One, that most people working in governments are actually really good people who are overworked and underpaid. And second, they lack access to the expertise and understanding of the changing landscape around technology and how that can help their endeavors. And I reflected on and designed a kind of framework regarding how to move global surgery forward. I call it the three I's. It involves investigation, innovation, and implementation. So my strength was in innovation and implementation with starting companies. When I looked at the numbers that existed, I looked at this other framework, the surgical system as the three delays. And here, this is a common global health understanding where patients are unable to get care at multiple time points. They don't know they need to go to the hospital, so seeking care is an issue. Then getting to the hospitals or getting to the doctors is an issue. And then once they're there, they may not be able to receive the care because of lack of supplies, lack of doctors, and nursing. So at all of these points within the system, there's opportunities for optimization and innovation. So I took on my role in global surgery around innovation. And I felt that this is needed in addition to all the other work that's being done to close this gap. So let me define to you what innovation is to me. It's the design, invention, development, and or implementation of a new or altered product, service, a process, a system, a business model, or an organization structure. Now, most people think of products. They think of things you touch, medical devices. But it's not just about that. It's about processes and systems. And innovation could be incremental, so small improvements on something, or it can be disruptive, where it suddenly changes the entire industry. I'll give you some examples. And in general, products are the easiest. And the hardest are changes in organizational structure. So here's an example from Brazil, where they use tilapia skin from a fish farms to use as burn for wounds for burns. Another one, it's called Slingshot. This is a zip line from came out of the Bay Area, but basically using drones to deliver essential drugs and medicines, initially in Rwanda, and now it's being used in Ghana. In Zambia, they developed a mobile surgical truck unit where they had 70 of these trucks that would travel in the rural parts of Zambia with feeder trucks going back and forth, delivering surgical care to the most rural parts of Zambia. Now, in India, Dr. Devi Shetty started Narayana Health, which is a very unique hospital, cardiac hospital, and they're able to drive down the cost of care through volume and economies of scale. So I asked myself, how could we increase local innovation? Right? Innovation that's performed in other countries is often not transferable. What we need to do is build capacity locally. The intelligence is local, but the resources, the experience, the mentorship is not. That led me now to developing surgical innovation workshops. And I started working in India specifically because India, unlike other parts of the world, it has every aspect that is needed from money, intelligence, education, and resources, but it also has all the extreme disparities in the rural communities. So in one area, I could potentially develop local capacity to then experiment and trial solutions. This is a picture of our team. We're running innovation workshops, and we chose second tier, third tier universities where people who go to those schools stay locally. They're not traveling, they're not going to Microsoft or Google. And we chose universities and schools that were in rural communities. We led these workshops where we would tell them about global surgery as a whole, and then we would invite local surgeons and nurses, providers who would come and talk about their problems, their statements, and we lead a series of hackathons. And we had the classic, Stanford School of Design thinking methodology, where we take empathize, you define, the ideate, and prototype, and test. And in fact, I did a series of Marshmallow Challenges with as a icebreaker to break down the barriers between faculty and students. Now, if you're not aware of this challenge, what you do is you place a marshmallow on top of a spaghetti tower, and you only have about 15 minutes, and you have dry spaghetti, marshmallows, and tape. Here's some photographs of the students working collaboratively across, faculty involved as well, building their little marshmallow towers. And in fact, we did this over a series of 3 years. We had almost 2,000 people attend and participate. We had this in India and Rwanda and other places. That led to developing a new model, a new framework to think about hackathons in LMICs. We call that Surgathons, a new model for creating a surgical innovation ecosystem in low resource settings. You can have, this is an open source BMJ global health paper, but at the pillar of it was global surgery. We talk about education, research, and advocacy. We talk about the skill sets and the framework around innovation, and then ethics, right? About understanding individual experiential learning, institutional capacity building. So discussing about everything from faculty training engagement to policies around patents, and then also community engagement. How do you optimize and engage the local community to participate? So my work has kind of gone through this process of entering global surgery, looking at the lens of working with governments and health systems. Then I've stepped back and identified innovation as a key component. I've now launched and helped bring together vascular anomaly centers. That's my clinical work. So trying to bring my clinical work now and developing centers and training locally. And over the next several years, I'm moving now to very specifically around oral and maxillofacial surgery. One of our first projects is around identifying all of the OMFS surgeons in the world to understand the distribution of the workforce. Is it the same? Is it worse than ENT or plastics, or is it better? The reason why this is important is there's a whole movement and a whole field. And if we don't have the data, and if we're not at the table, we won't be able to contribute to helping the 5 billion people who are needing basic surgical care. I want to thank you. I want to remind you that everyone has a role to play in advancing society. And on my left here, this is my current amazing lab with students and Jack Harris and Kumar, with Chris Mon, Emily and Con, Nicole and Daniel Shen. And they are leading the projects that we're doing forward in OMFS and global surgery. I have questions.
Awesome. Thank you, Dr. Afshar. That was a wonderful presentation. I do have a couple questions that you can answer as we wait for Dr. Aziz. One question someone asks is, what does meaningful engagement in capacity building efforts look like for students and trainees?
So, that's a great question. All of my work begins with friendships. It's about building real friendships with people. And once you build the relationships and friendships, you have to work together, try to figure out things, try to solve things. And as students, the most important thing is start building relationships. Through GSSA and other organizations, you'll meet people, like-minded people. You can have discussions on social discourse, but it's about thinking long-term. Everyone that's on this call, including myself, we're all the same. We're all going to be colleagues trying to figure out our path of service. And when you do that, when you see the unity amongst all of us, then the next step is much easier. And the capacity building will then come, which is accompaniment, right? Walking with people. So you'll have some skill sets or access to certain things that others may not. And you will share that and accompany people And that becomes part of the capacity building locally. You'll be able to share knowledge. So for example, with the university you work with, they never ever had multidisciplinary work or interdisciplinary work. So the capacity building was at faculty level, at policy level, and breaking down some barriers regarding hierarchy. A lot of it's not publishable, and that's fine. You're not doing this for publishing. Right? You're doing this because it's something you're passionate about.
Thank you, Dr. Afshar, for that answer. That was a wonderful response. One of the panelists or attendees asked, what are the limitations to performing oral and maxillofacial surgery in the US compared to abroad?
A broad question. So limitations in regards to a couple of things. Definition of oral and maxillofacial surgery varies. In many parts of the world, there's maxillofacial surgeons and there's oral surgeons. Oral surgery is to dental, maxillofacial is to a medical training, and mostly head and neck pathology. So if you talk about clinical barriers, it's mostly around, so it can vary country by country. The other aspect is numbers. So in Zambia, a country of like 16 million people, at that time, I think there was like one oral surgeon in the country that was formal oral maxillofacial surgery. Now there's dentists and there's other people, but it's always, ultimately it's around workforce numbers. It's the biggest limitation regarding access. And then training. So currently I'm building a relationship with Tanzania. Tanzania, there's 6 young oral surgeons who are going to be the next generation of faculty. And so I'm working with developing a partnership with them where I will share with them cases, give them lectures, I'll be there for them to kind of think through treatment planning. But they're seeking to build these relationships. And with technology today, with Zoom, and other means, it's much easier to have these international collaborations and friendships and support each other.
Awesome. And to follow up on that, one of the attendees asked, what is the particular reason for why you chose to launch projects specifically in Zambia and Rwanda?
So Zambia, at the World Health Assembly, where it was announced that surgery is part of universal healthcare, that's a huge resolution. Right? Universal healthcare is a big topic in global health. And surgery was never, ever included in that. Global health was dominated by infectious disease, HIV, malaria, and then next was all the pediatric OB, child-related stuff. When surgery was announced through the General Assembly resolution, Emmanuel Makasa, who is the representative from Zambia, raised his hand and said, we will be the first country. So it's about stakeholder buy-in. So Zambia was the first and willing to go abroad. Now, since then, there's been dozens of countries who've gone through the process. And it's a big process, right? It involves governments to go through a process of auditing and reflecting and costing. I mean, it's a lot of effort. I mean, it took us a year and a half of working in Zambia to do that across the entire country, visiting facilities. Where are your doctors? Where are your students? Right? Mapping out the pipeline from education to being in the field, where the gaps are within each province and city and town, and then developing a strategy of where you're going to invest money over the next 5 years. Where are you going to build new facilities? Where are you going to send new doctors? Where are you going to, where are the issues of supply chain management? All these other various things. So Zambia was first one. Rwanda also had a, so it's all about receptivity, right? It's about those who want to work together and collaborate. None of my work involves exchange of money. So I am not a funding source. And it's intentional. Because oftentimes when you have funding, say you have a grant or so forth, that can cause asymmetry in power. People will often feel that they must do it because you have money and so forth. It just changes the dynamics. But by being there just as a resource and building friendships, it makes it much more collaborative.
Wonderful response. Next question is from Emily. I guess you know her. She asks, is oral and maxillofacial surgery a recognized specialty everywhere? If not, do we know who covers procedures that we traditionally consider in the oral and maxillofacial surgery scope? Which procedures within this scope do we prioritize when aiming for sustainability?
Okay, that's great. Well, that's something to be defined and explored with our field. Meaning, so what the first paper we're doing right now is around identifying where are the oral surgeons, where are the scope, right? Because no one knows, right? No one knows. Most of the international associations are those from high income countries, but we don't know the situation in low to middle income countries. We don't know the policies. No one's ever documented. So the effort, these questions are great questions. And these are the areas that we have to do research. And then once we have that data, then we start to innovate and figure out, okay, how do we solve the gaps? I can tell you in other specialties, other fields, there are gaps in countries that collaborate. They're like, okay, we want an oral surgeon, we want 5 oral surgeons. And we need them for these essential infection, trauma, right? The basic will be infection, trauma, and head neck pathology. Those are big areas. Things are like cleft lip and palates. That's a lot of crossover with ENT, plastics. But it's amazing is most oral surgical work, most head and neck work is done by general surgeons, just because of the lack of access. I have friends who will WhatsApp me, with a large head neck lesion, and they'll ask me if I can guide them through this. So the lack of oral maxillary surgical surgeons, head neck surgeons, is there. And then those that do exist are usually dealing with adult oncology.
Great, and I see that Dr. Aziz has entered into the meeting today. Dr. Aziz, feel free to bring up your slides and share them with all the attendees and the panelists. I will just quickly introduce you as I already have, but Dr. Shahid Aziz is the professor of oral and maxillofacial surgery and plastic reconstructive surgery at Rutgers University and co-founder and president of Smile Bangladesh, which is a nonprofit medical organization dedicated to caring for children and adults afflicted with facial cleft deformities in Bangladesh and around the world. Dr. Aziz, the floor is yours. Oh, Dr. Aziz, you are muted.
There we go. All right, good. Can you guys hear me now?
Yep, we can hear you.
Perfect. All right, so again, Jack, thanks for having me. Thanks for the invite, and it's really a pleasure to be speaking to all of you. I apologize for running a little bit late, but as those of you who are either oral surgeons, or oral surgery residents, or future oral surgeons know that sometimes it's unpredictable, your day in the operating room. So any case, I'm really happy to be here. So, Jack had asked me to speak a little bit about my take on global oral and maxillofacial surgery. So I wanted to give you some thoughts about what I think that's all about, and tell you a little bit about my experience with it for the last 20 years or so. Last summer, I had the privilege of editing and writing a OMS clinics in North America that was dedicated to global oral and maxillofacial surgery. So, if any of you have an opportunity to get a hold of it, or if you'd like to get any PDFs of it, let me know. I think it's a good read. And my co-editors were my dental school classmate, Jose Marchena, and who's
Dr. Aziz, have your slides up?
I'm sorry, what?
Are you trying to see
slides? Can you not see my PowerPoint?
No, we don't see. We see a browser.
Oh, hold on.
Yep, you might just have to switch the screens.
Yeah, hold on. Sorry. Mhm. All right, how's that? Any better?
Now they can put them in presenter mode and they should work.
Okay, so you can see my PowerPoint.
Yes.
Okay.
Yes.
Sure. Sorry about that. All right. So anyway, as I was mentioning, this is clinics. I think you all should take a peek at. I think it's a good read for those of you who are interested in global surgery. It was co-edited by Dr. Marchena, who's down at UT Houston, and my mentor, Steve Roser, who's currently the chair at Emory in OMS. So I'm sure Dr. Afhsar mentioned the Lancet Commission, but I think they have a great definition for global surgery, and it's basically an initiative with the goal of providing universal and safe access and affordable surgical and anesthesia care when needed, which saves lives, prevents disability, and promotes economic growth. And in the last, I would say, decade, this sort of philosophy about global surgery and the importance of global surgery and why we should do global surgery has sort of gelled. And there are multiple major surgical organizations led by the ACS, as well as the Royal College of Surgeons of Edinburgh and the Royal College of Surgeons in the UK, that are really leading the charge to promote global surgery. And why do you do that? It's thought that 30%, about a third of the burden of global disease is surgical in nature. And 5 billion people globally do not have easy access to surgical or anesthetic care. 5 billion, that's over half of our world. So that's a really significant statement and an impactful statement, that half of the people in this world do not have easy access to surgical or anesthetic care. Almost 150 million additional surgical procedures are needed, it's estimated, to save lives and prevent disability. And more of this can be read at lancetglobalsurgery.org. This is from Global Surgery 2030, which is a report basically outlining the goals and objectives of meeting some of these needs. Specific to oral surgery, what is the global burden when it comes to oral maxillofacial surgery? The biggest one is head and neck cancer care. Outside of North America, oral and maxillofacial surgeons are in many places head and neck surgeons and oncology surgeons. And head and neck cancer is a major head and neck oncology is a major burden, especially in the developing world. In the Indian subcontinent, head and neck cancer is the primary cancer, the primary malignancy, and throughout the sub-Saharan African continent as well, same thing. Other issues, facial cleft surgery. I think anyone who is involved in plastic ENT or OMS surgery knows about cleft missions and facial cleft surgery, but it really is an important burden that we've done fairly well in certain parts of the world, I think, tackling. I think that, American surgeons have dealt with this for 30 to 40 years, but they primarily focused on Central and South America. I'm originally from Bangladesh, and I started going to do facial cleft surgery in Bangladesh nearly 20 years ago, and there was a fantastic need because they really had no training or education or access to care on the patient level. So when it comes to facial cleft surgery, it's an interesting topic globally because there's certain parts of the world and the developing world that have really good access to care because, South America, it's a quick and easy flight for most surgeons in the States. They come down, they go for a week, and then they come back. it's sort of global tourism. That's something we really don't want to aspire to. What we want to do is, if we're doing global surgery, is going to fulfill the needs of the underserved, but also stimulate infrastructure, meaning training local surgeons to do these surgeries, following up on surgical care, things like that. A couple other topics or areas for global OMS burden: orthognathic surgery, or the treatment of underbites, overbites, etc., which can be potentially debilitating and functionally an issue. Very popular surgery that's done here in the States, but throughout the world, it's not necessarily, especially in the developing world, it's not necessarily a surgery that's often done. And I'll talk a little bit more about that and my experience with that in Bangladesh. And finally, basic oral surgery, dental-alveolar surgery, and the treatment of odontogenic infections. And I think really between cancer and infection, these are the two biggest burdens of global OMS, because those are the two areas that can be potentially fatal, cancer and really terrible infections. The biggest issue, I think, with the burden is access to care for individuals in developing nations to adequate OMS facilities and OMS surgeons. And so one of the things I mentioned a second ago was the ways to overcome this really have to do with infrastructure. You have to provide more access to care, but to do that, you have to improve facilities, and you have to improve and increase the number of surgeons. How do you do that? You have to educate them. And you have to provide training programs in the developing world, in low and middle income nations. You have to provide education, open dental schools, open oral surgery programs, and provide educational opportunities for all of that. And ideally, in an ideal world, you offer programs where individuals in low and middle income nations can be cross-trained. They're able to come to Europe or North America to get some more training and more specialized training, and take it back to their home, and in turn train the next generation locally. So I think those are really the ways to defeat that global burden in OMS surgery, or just surgery in general. And that's improving facilities, improving access to care, and then local training. And I think that anyone who does global surgery from the US, I think they're obligated to not just go and do surgery, because really that's just global tourism. I think really what they need to do is train while doing surgery. So I think education and training is really important for the future of global OMS surgery. So again, as I mentioned, develop infrastructure, and that's developing access, facilities, and education. It is much easier said than done. It's not a simple thing, and it really, the bottom line, like almost anything in life, requires money, requires funding. But to a certain degree, I think it requires a mindset change, because when I initially got interested in global surgery as a resident 20 plus years ago, I really didn't think about the impact that I could have on the country. I really didn't think about necessarily how I could make these opportunities sustainable. What I was interested in was traveling to, another part of the world and learning how to do facial cleft surgery and making an impact on those children. That was my sort of mindset when I was a resident. But as I've matured and spent a lot more time doing international surgical initiatives, I realized that, what we really want to do is not just the surgery, but we really want to leave a legacy and help develop an infrastructure, and that requires education. It requires a mindset change that we're not medical tourists. We're coming here with a long-term initiative, wherever you may go, with a long-term initiative to ultimately train and educate the local surgeons so that they no longer need us. Case in point, there was a small rural hospital in Cox's Bazar, Bangladesh, which is where, if you know anything about refugees around the world, the Rohingya refugees are really based in the UNHCR camps in Cox's Bazar. So, they've been there for years, and some of our patients were Rohingya refugees. But my point being, this was a site that we went to for years, 15 years ago, and we started training local surgeons. And after about 7 years of repeated missions, they finally got to a point where they said, we don't need you anymore. And rather than being disappointed, I was pleased, because that was my really game plan, in that I educated the local surgeons. I provided enough infrastructure as far as obtaining donations to help build ORs and equipment and things like that, and then training surgeons so that they don't really feel they need me anymore. They're comfortable doing it themselves. And that's really what we need to do, I think. There are a lot of benefits in participating in global surgery throughout your career, regardless of where you are in your surgical career, whether you're a student, whether you're a resident, whether you're a junior attending, junior faculty, or more senior. It's a great experience. It provides a very unique experience. It, in my experiences as a student and a resident, and now on the opposite side of the or table as a attending, it's an opportunity when I was training to work one-on-one with a senior surgeon. And now the flip side is true. I work one-on-one with one of my residents, for example. And it's a great experience to work one-on-one with that person on an interesting case that we may not necessarily do as frequently in the States. But for me personally, I think the biggest issue, or the biggest reason I take students and residents, is that I want to have them catch the bug of global surgery, meaning that I want them to be inspired to give back in their career. I think we're all blessed with skills, this skill set to be oral and maxillofacial surgeons, or any type of surgeon. And I think, we need to give back to make society a better place. We're all going to live comfortable lives. We're all going to work hard, but reap the benefits of that. And I think it's important that we all, at some point in our careers, give back. These are some programs that I could think of that are actively doing global surgical work that are run by American oral and maxillofacial surgeons. From Bangladesh, it's run by myself and Jose Marchena, who I mentioned before. Healing the Children has a lot of chapters throughout the country, and they have oral surgeons throughout the country who are doing missions to different parts of the world. Health Volunteers Overseas is a organization that is directly affiliated with the American Association of OMS, and they have a couple opportunities in South America. And finally, Mercy Ships, if you ever have a chance to read about Gary Parker. So Dr. Parker, is a real inspiration. He's the medical director now of Mercy Ships, but he basically spent his career on Mercy Ships, which is our hospital ships based off of the coast of Africa, providing, free care to, those in need. And, a lot of what he does is head and neck reconstruction, facial tumor, benign and malignant tumor ablation of the head and neck. And it's really, if you ever have a chance to meet him or speak to him or read about him, he really, truly is what global surgery is all about, in that, he's providing care to the neediest. He's training people. He's facilitating care. And so I have really a lot of admiration for Dr. Parker. So I wanted to spend a few minutes talking about my organization, and it's known as Smile Bangladesh. It's a nonprofit that I started almost 20 years ago here in New Jersey. I think this photo is a really good indicator of the need for cleft surgery, facial cleft surgery in rural Bangladesh. So this is a photo that was taken about 10 years ago. It shows a mother and daughter, a 20-year-old mother, a 3-year-old daughter. And you'll notice they both have primary cleft lip deformities. And so what that tells me is that, you know, there's obviously a genetic component to facial clefting, but also the fact that a 20-year-old was unable to have her cleft repaired tells me that in rural Bangladesh, tells me that there probably wasn't either access to care or she couldn't afford care. And so, you know, this picture sort of tells me that, you know, you interpret it to mean that there's a huge need for maxillofacial surgery in rural parts of Bangladesh. So again, we're a New Jersey-based nonprofit. We're a 501c3, and that's very important because it opens up the opportunity for us to obtain different types of grants. That's our website, smilebangladesh.org. If you want to check it out, that would be great. And our goal is to provide medical, surgical, and dental care for indigent children and adults with facial cleft deformities in Bangladesh and around the world. If you don't know where Bangladesh is, it's a country that is encircled by India, basically, with a little sliver of it bordering Myanmar. And it's one of the most densely populated countries in the world. It's the size of the state of Idaho, but it has 162 million people in it, or half of the population of the US, basically in one state. So it's extremely densely populated. So since 2015, I think, or 16, sorry, 2006, we've been running missions. We've done 24 missions over the last 16 years. From 2006 to 2019, we've treated over 1,600. We've done 1,600 or more surgeries for free. And we're hoping that our next mission is going to be this November. Now, all of our, obviously, our 2020 missions in March and November were canceled because of the pandemic. And our March 2021 mission was canceled because of the pandemic. And again, we're hoping to go back in November. What is going on in India right now may force us to postpone that until March of 2022. But, you know, I'm keeping my fingers crossed that we'll be able to go. Why Bangladesh? Well, the most obvious reason is that's where I'm originally from. That's where my father's from, my family's from. And they have a huge need for maxillofacial surgery. In the literature, they estimate, and this is about 10 years old, from an article 10 years ago by the Bangladeshi OMS Society, it's about 300,000 individuals, children and adults with unrepaired cleft lip and palate deformities. And at the time, there were only about 30 surgeons in the whole country with formal training. So that's a really tall task to try to meet. It's a really tall mountain to climb. It's also estimated that the incidence of facial clefting in Bangladesh is twice that of the US, where in the US it's 1 in 1,000 births, which is pretty common throughout the world. Bangladesh, however, it's 1 in 500, and that has to do with multiple reasons. Genetics, obviously, folate deficiency or malnutrition during pregnancy. But I personally believe that in rural Bangladesh, the biggest two reasons are consanguinity. So first cousins marry first cousins. So you have, obviously, when you're sharing the same gene pool, you're gonna have a much higher rate of birth defects. And also early pregnancy. You know, the average marital age in rural Bangladeshi communities is 13, 14 years of age. And girls are often not physically ready to handle pregnancy, and that in turn can lead to a higher incidence of birth defects. The team I take about 3, maybe 4 surgeons. I should update this slide. I take more anesthesiologists than surgeons. If I'm taking 3 surgeons, I'll take 4 to 5 anesthesiologists. And why do I do that? That's simply because the riskiest part of these surgical missions is the anesthesia. Repairing a cleft lip or palate, for example, is not going to cause significant morbidity to the patient, but a bad anesthetic will. So you need experienced pediatric anesthesiologists, and we need more than we need extra just in case there's emergencies. Sometimes they'll bring a pediatrician, but more often than not lately, we're utilizing the local pediatricians. We bring scrub nurses, we have an administrator who does all the coordination. And finally, we bring residents. And I think that's a great opportunity for residents. As I mentioned before, a great experience seeing not only just another part of the world, but also from a surgical standpoint. You know, they're spending a week of intense surgical training one-on-one with a attending plastic or oral surgeon. And it's really a great educational opportunity. And the goal for them is really not to make them, you know, Paul Tessier, but it's to make them inspired to give back in their careers in some way, shape, or form. So this is, I like this photo simply because these are a couple kids lining up for surgery a couple years ago. The young man on my left, maybe purposefully or not purposefully, is giving me the finger. So I got a kick out of that photo. But again, you know, these are individuals who need the surgery, and obviously this is from one of our camps where kids are lining up to be screened and prepared for surgery. And these are just some other pictures of some of the kids that we've operated on preoperatively over the years. So this is, I put this picture up for a couple of reasons. So one of the things that we do is that we have about 5 or 6 centers that we're affiliated with in Bangladesh, and we sort of rotate between those centers every 2 years. We'll come back. So this, for example, on the left and right, it's the same patient. So this is a young girl. She was about 10 months old. On the left, about to get in to surgery. We're about to take her in. She has a complete cleft lip and palate, alveolar cleft deformity. This is her 2 years later, a couple hours after she had her palate repaired, which is why she has a little bit of a bloody nose. But you can see the difference in the lip repair, and you know it's life-changing, I think, really for on these kids. And the fact that we go back to the same place is important because we can do proper follow-up, see the same patients, continue their care. But also it's very important because we have an educational component. We're training the same doctors, the same surgeons, so they get better at doing these procedures by themselves. One of the things that I found that was really unique in Bangladesh was you had teenagers and young adults with unrepaired lip deformities, and that tells you again there is an issue with access to care in rural parts of Bangladesh. This is a 20-year-old, and you know, as you get older, your deformity gets wider, and you know, this is him asleep on the left, and this is him, you know, that afternoon after his 45-50-minute repair. And so, you know, obviously making a very big difference in this young man's life. This is a 60-year-old who lived along the Myanmar-Bangladesh border, which is why she has a little bit of that South Asian reverse Far Eastern look. And again, 60 years old, she never really had access to care to get her primary lip deformity repaired. And so this is her, you know, pre-op and then waking up from anesthesia. this is at that facility I talked about by Cox's Bazar, where the refugees are. And we spent a lot of time educating the local surgeons. We spent a lot of time also pumping money into the facility to build up the OTs. Literally, the first time I visited it, just to check it out for a future surgical camp, they didn't have proper floors. They had dirt floors. It was just like walls set up with dirt floors and a roof. And so we invested a lot of time and effort, on the infrastructure so that it would be a safe place for surgeries of all type. You can see in the back, one of my colleagues in New Jersey, she donated the air conditioning unit, for example. We spent a lot of time fundraising to build the floors, get the proper anesthetic machines, things like that. So building infrastructure. Got the infrastructure, then we spent the next several years training the local surgeons. So they got to the point that they were comfortable treating these patients, and they didn't need us anymore. And that's a win in my book. This is another example, and this is a 68-year-old farmer who just wandered in one day to one of our camps and had a bilateral incomplete cleft lip. You can see him here. He's falling asleep on the OR table, and this is him waking up in the PACU. And again, it makes a big difference, a quick surgery in these people's lives. And the fact that you're doing it on people who are literally elderly means that they really didn't have access to care. And this is why, what we do, or what the potential and opportunity of global surgery is. It changes people's lives for the better. In the last 4 or 5 years, I've been working more and more with the Bangladeshi OMS Society, and one of the things they really wanted to learn about and be trained in addition to clefts, is orthognathic surgery, which happens to be, my forte. That's what I do in the States. I do, 200 of these type of surgeries a year, which makes me one of the more busy orthognathic surgeons in my area. And there was a big desire to learn how to do this for a couple of reasons. One, it's obviously a major part of maxillofacial surgery that they were lacking. Two, the orthodontic community in Bangladesh is evolving. And orthodontics, or braces, and orthognathic surgery sort of go hand in hand, as I'm sure some of you know. So there was a big interest on the dental community and the surgical community to develop orthognathic surgery. So I worked with the OMS Society of Bangladesh and created a training program for orthognathic surgery in that country. And our first formal program was about 3 years ago, where we had a symposia combined with cadaver surgery, which basically myself, Dr. Marchena, we would be operating on a cadaver. We were mic'd up and we would be talking through the procedures. We would lecture on it in the morning and then do it on a cadaver. And we would be mic'd up, and they would also be videoing us, and we would be simulcast into another room. And throughout the process, we would be asked questions, as we went through, the Ford, sagittal split, et cetera, et cetera. There were a couple issues from this. This was sort of a preliminary thing that I put together. And, there are some language barrier issues. There were some resource issues and instrumentation issues that I had to work on for future symposia. And this is just, this was at a dental school in Dhaka, which is a capital. And again, we had a symposia in the morning, basically doing about 6 hours of lecturing on different topics in orthognathic. Had about almost 300 surgeons and dentists in the audience. And then we went on to doing cadaver surgery, in which it was simulcast. The next step in this program is actually doing live surgery, and that we planned the following year, combined again with didactics. And what we did was I go to Bangladesh twice a year. So in March of 2019, I met a handful of patients who were looking to do orthognathic surgery. This is one of them. This is a young man who was born with a cleft lip and palate deformity, had it repaired, but he also is severely class 3 with an alveolar cleft. So we did the alveolar cleft in March, and then got him prepared for his orthognathics in November. And you can see he's severely class 3. If there's anyone who is not of a dental background, it means he has a severe underbite. And this is just me in March, meeting him for the first time, looking at his films, reviewing his casts, etc., and just sort of planning out his surgeries with the locals in Dhaka. I was able to get a CT scan on him through the hospital in Dhaka, which I could then bring back to the States and surgically plan his case. We did the case. This is one of my partners, Greg Jacob, and our associate, Jess Lee. And we were basically doing multiple surgeries, live surgeries, and it was a little bit disconcerting, but they had us videotape while we're doing it and mic'd up. So it was a little bit different than obviously what we do in the States, but again, it was for educational purposes. We had surgeons in another room watching us operate, asking us questions, and we were also talking through the procedures. We did a Lafort and extraoral vertical ramus osteotomies and a genioplasty to treat his class 3. You know, this is him a couple months post-op. Again, because of the pandemic, I haven't had a chance to see him, but I do keep in touch with him. WhatsApp is a beautiful way of communication internationally, so he and I actually do keep in touch as far as his progress. Other cases that we did, this is a mandibular asymmetry that we did sagittal splits on. And again, we had local surgeons scrubbing with us so we could start training them. This is Dr. Lita. She is the chair of OMS at Dhaka Dental College, and which was our host. And again, this is us taking her through a sagittal split. And then had an open bite case that we repaired as well. And then finally, we did a couple days of lecturing. And one of the things that we did also is I brought an orthodontist from Rutgers, Dr. Mukherjee here, who talked about surgical orthodontics. So I think it was a well-rounded lecture. Then, of course, the pandemic happened, so we got sort of held up. But we are working on continuing this program with more surgery and lecturing and didactics, case conferences, things like that. And, you know, during the pandemic, we actually had a 4-hour Zoom conference with the OMS Society in Bangladesh on orthognathic surgery. Again, lecturing and case discussions, you know, presenting cases and letting the audience ask questions and try to think things through on how to work up and treatment plan these procedures. Finally, I wanted to conclude by talking about the pandemic. So I think the pandemic is going to, or has taken its toll sort of on global surgery for the last year. And we're starting to come out of it here in the States, but obviously there are other parts of the world, such as India, that are really, suffering right now, the way we were a year ago. And so I would tell you that there's a great article that I co-authored. Victoria Mannion, who is a OMS resident at UT Houston, myself, and a couple other people from Rutgers, wrote a really, I think, a great article in Maxillofacial Trauma and Reconstruction from a couple months ago on resuming global surgery, global maxillofacial surgery in light of the pandemic. So if any of you have an opportunity or an interest, I definitely would read it. And I think that concludes my talk. I'm happy to take any questions at this point.
Great. Thank you, Dr. Aziz, for sharing your experience in global surgery and the Smile Bangladesh. So now we will just open it up to a couple questions for Q&A, and then we'll wrap it up. So one of the attendees asks, is there an inadequate oral and maxillofacial surgery presence in the first place? For example, in places such as Bangladesh? Do you train general surgeons to take some of this burden, or do you try to train more OMS from the ground up for a greater future impact?
So there's a huge lack of oral surgery presence and training, again, in Bangladesh, for example, which is the place that I know. There are 2 training programs in the whole country. And again, the country is half the size of the US. So there's a huge lack of properly trained clinicians in oral and maxillofacial surgery in Bangladesh. I mean, in the States, we have, 100+ training programs with, over 1,200 residents. Bangladesh should have half of that, and they have a fraction of that. So there's a huge lack of education, lack of training, lack of facilities, and lack of surgeons, and there's still a big need. So, one of the things that's important, I think, is education. And, we are involved with both training programs. We do get faculty and house officers from those training programs to get involved with our activities. We also have ENTs that are also involved with what we do. And really, it's just education, I think, is the way to solve a lot of these issues.
Wonderful. We also have another question for either Dr. Aziz or Dr. Afshar. So what political, legal, or licensure restrictions do you run into when doing global surgery abroad?
I will tell you, from my standpoint, we need to have the blessing of the health ministry. You don't want to go without notifying the health ministry. And I think that's by and large any place internationally, because you just don't want to get in trouble while you're out there. And so you need some sort of documentation from the health ministry to say, hey, we know you're here and we are allowing you to provide care to whomever in our country. So I think that's very important.
I'd like to add, same thing, just engaging the Ministry of Health, having the government blessing is key for anything you do.
Wonderful. Thank you for that response. Another question is, how can oral and maxillofacial surgery residents and dental students best contribute to the mission of global surgery in a meaningful and impactful way?
I think it's difficult from a student perspective, but I think that what you're doing, what you guys are doing right now is very important, which is finding out as much as you can about global surgery, creating clubs within your dental schools that are focused on global surgery. And I would say look for opportunities for global surgical missions that you could participate on at different levels. And it doesn't necessarily have to be something as fancy as cleft surgery or orthodontic surgery. It could be simple as, going to an underprivileged part of the world to do dental alveolar surgery, for example. But I think that for a dental student, that's a great way to start to get involved, and I think also just learn about it. Salim, if you have any thoughts.
Yeah, and I think there's as I spoke earlier, there's a lot of different avenues. Global surgery is a evolving field, and as students, there's opportunities to look at. So most of the global surgery activity that's being done by students are either anesthesia and or general surgery interested minded individuals and or those residents. So, as I'm a faculty member in the program in Global Surgery and Social Change, every year we have enrollment for 1 year research associate, or you do multiple year, do time off to do be a Paul Farmer Global Surgery fellow. And these are opportunities that are not isolated. We've had plastic surgery residents and people interested in plastic surgery, students from medical students from other parts of the world, as well as the U.S. do this. I think there's opportunity around research. As I mentioned, we're trying to, one of the projects I'm working on is to try to identify what is the distribution of home fests around the world within these countries. Is the same, and to be part of the social discourse around oral surgery is an essential part of surgical care delivery and an essential part of healthcare delivery. So I think there's those opportunities around advocacy and research as well.
Great, thank you both for your responses. Another attendee asks, what are your opinions on social media and its potential for influencing the future of global oral and maxillofacial surgery? How, if all, can it be best utilized, i.e. raising patient public awareness, education, delivery, research, etc.?
Salim, do you want to?
So I think social media is very powerful. As Dr. Aziz mentioned, WhatsApp is, I have such a busy Telegram, WhatsApp, accounts with my friends and colleagues in India, in Zambia, all other parts of the world. And I think the part of increasing our presence and having a long-term impact in helping governments and universities develop exchanges and fellowships and just create change, even within the US, giving credit for residents who spend time with a board certified faculty. These are things we need to be doing from an advocacy standpoint. And social media is very powerful from that standpoint, that we have to have a presence in the discourse.
Yeah, I agree. I think social media is the wave of the future. I mean, WhatsApp is an amazing way, as Salim mentioned, to keep in touch. We use that and Skype to kind of follow up on patients. But it's a great fundraising tool. It's a great way to get your message across. And it's just a great way to connect and stay connected. So, social media is a really wonderful avenue to bring us all together.
Also, oftentimes traditional path of communication for academia is only through publications. We have found that creating these infographic abstracts is very powerful, where we capture the key components of a paper, for example, and push it to Instagram or to Twitter. It enables people to understand the why, the need. And I think we have not done a great job to bring to light the need. Dr. Aziz's work is amazing. Bangladesh, this highly dense country that is right next to India, you would think people would assume there would be an issue, but there's a huge need. And I think this is some of the opportunities to be able to get the message out there.
And Dr. Aziz and Dr. Afshar, do you see more telemedical or remote communications occurring with global surgery now and into the future? And if so, what is its role?
Well, for me, I mean, obviously the pandemic has sort of made us a lot more comfortable with telemedicine, telehealth, because that's something that, we were sort of forced to do during the COVID pandemic. But as I alluded to, I think that, that's how we've always sort of followed up on our patients. We would leave and we would, have weekly follow-ups and see how everyone's doing. We would try to coordinate, a Skype or WhatsApp call, video call when they're doing their follow-ups. And, granted, it's a 12-hour time difference. So, I was up at the middle of the night sometimes looking over patients, but it is what it is. And I think it's a great educational tool. As I mentioned before, with Zoom, we were starting to have more and more Zoom conferences in Bangladesh, for example, educational conferences and case-based discussions and things like that. So I think again, social media, telehealth, all of this stuff is bringing us all closer together.
Yeah, I just want to echo, and I'll work on, I'll set off on Dr. Aziz's work. He has established relationships and trust over 20 years. That now becomes a beachhead, an avenue to expand. Part of creating sustainable change is by assisting local people, both in education and training, but also in identifying or being able to do research locally so that they can go and make policy changes locally. So ministers of health, for example, who dictate investments in education and residency programs, they need data regarding the burden of disease, for example. And I think the students, residents, and these programs that have been long-term building relationships, we can start supporting during non-clinical events, right? So once you're back, the work is being done. So we've worked on trying to increase capacity building around research locally, and that can be further supported with telemedicine and WhatsApp, as well as triaging of cases and doing a lot more didactic work where people have become more comfortable with that, beyond just the clinical care as well.
Wonderful. Thank you both for your insight. So that wraps up our Q&A session. Do either of the panelists have any final comments or things they would like to say before we wrap up?
Well, I encourage all of you. I thank you all, first of all, for taking time out of your schedules to get together tonight to talk about this subject. And if any of you have any interest or need particularly any advice about global surgery or careers in oral maxillofacial surgery, you're more than happy to reach out to me. I'll put in the chat my email. And, I really appreciate having the opportunity to speak tonight.
Likewise, I think it's really exciting to see this much interest and the future of being more cohesively connected with the global health and global surgical movement.
Wonderful. So I would like to thank everyone for attending. If you are a current dental student, medical student, resident, or fellow who wishes to become more involved in global surgery, please see the Global Surgery Student Alliance's website at www.globalsurgerystudents.org. Also, if you are a current dental student and wish to start a Global Surgery Student Alliance chapter at your dental school, please feel free to reach out to GSSA or myself at jack_harris@hsdm.harvard.edu. On behalf of the Global Surgery Student Alliance, I would like to thank you all for joining this webinar. Have a great rest of your week and take care. Thank you all.